for clinical officers.
Through this program, we plan to look into the history and the current situation of clinical medicine as a profession and how to even go through the career ladder to the topmost within the profession.
Our focus is purely about our enthusiasm as the Clinical Officers Union to inform our member about our history, being the longest serving.
Good afternoon. Thank you and welcome to our fourth session of KUCOEngage. We want to begin. Others will find us somewhere on the way. I am your co-moderator and I am moderating together with Philomen Mayek. Just before we start, I would want to invite one of us to say a word of prayer, and I request Dominic Reño to lead us with a word of prayer. Dominic, kindly, if you can hear me. Is Dominic in the call? If Dominic cannot hear us, then Stephen Mudama, kindly. Stephen Mudama, please lead us with an opening prayer. Nelson, please give Mudama the mic.
Thank you. Let's believe and pray. Father, we come before your presence this evening. We thank you for giving us life and time at this moment. We thank you for having created us clinical officers and proud souls. We thank you for taking care of us throughout difficult moments and good moments. As we get into this KUCOEngage meetings and deliberation, we ask you to guide us, guide our leaders, guide each and everyone. Let us have a good engagement, a positive engagement, and give us wisdom to find better ways to deal with the challenges, better ways to deal with all obstacles our ways. Give us insights and ideas to make ourselves much better than we've been. In Christ's name, we believe and pray. Amen.
Amen. Thank you so much, Mudama. Like I have said, this is our fourth edition of KUCOEngage, and it is a platform that we continue to use to amplify the voice and the role of clinical officers in shaping Kenya's health system. And today we are going to discuss SHA. And we know this is one of the areas where our interest has been focused in the recent past because of issues with the pre-authorization and our facilities, and we have walked our journey, so we will be able to find out where we are, and of course get to know what challenges are we still experiencing, and the opportunities that are there for us to grow as clinical officers. And with that, I want to bring in my colleague, my co-moderator, Philomen Mayek, to introduce our power panel and, of course, start us off with the discussion. Thank you.
Thank you so much, Madam Mary. Good afternoon, everyone. And this is a great opportunity for us to engage. I want to welcome each one of us and appreciate each one of us wherever they are. They have created their time to be part of this engagement. And I believe we are going to have a very fruitful engagement with each one of us. Allow me to introduce our panelists for today. Our topic for today is about SHA, and I know SHA has been a very big issue within us. I hope I'm very audible, Mary and Nelson.
Yes, you are.
Thank you. So SHA has been an issue that we are yet to have a full breakthrough in it. And I want all of us to be active. I want all of us to participate. I want all of us to engage so that at least by the end of the discussion, we are going to go back home with some good promises. So let me start off introducing Mr. Douglas Odhiambo, who is the acting department regional director, coordinator for SHA. I hope Mr. Douglas is in with us. Our second panelist will be Gilbert Osoro, head of public education and awareness. I believe Mr. Gilbert is also in with us. Our third panelist, we have Mr. Frederick Ouma Okwata, who is one of us, our senior clinical ophthalmic clinical officer, also working in the Ministry of Public Health. We also have one of our own, Mr. Eric Ondieki, a clinical officer in private practice.
Good afternoon.
Thank you, sir. We are also having Secretary General, Mr. Chebi Joseph, who is the Secretary General for the Kenya Clinical Officers Association. And we are having our very own GS, Mr. Gibore, who is with us. So I know we've been traversing this issue for quite some time. And I want to invite our GS, Mr. Gibore, to actually give us a brief before we now tackle the big agenda for today. Mr. Gibore, karibu sana. Bwana GS?
So the GS is on the road, actually. He will be joining us in a few minutes.
Okay, I don't know if Mr. Chebi is in the house so that he also takes us through the history. Nelson, kindly confirm if Mr. Chebi is in.
He is not in. Let me give you the chairman, Peterson.
Okay.
Yes.
Perfect. Karibu sana, Mr. Peterson Washira, Chairman KUCO. Kindly, the floor is yours. Take us through the history of SHA, where we are today. Thank you.
Yes, thank you. Thank you, Mayek. Thank you, Mary. And our panelists who have joined today. I hope I'm loud and clear. I hope you can hear me.
Yes, we do, Chair.
We can hear you loud and clear, Chairman.
Very well. I think Georgia was supposed to be taking care of today's meeting, but I'll be able to join later. But I think I can do what you have asked. A brief history of where we have come from with the issue of the NHIF and now the Social Health Authority. From the year 2018, we have had a struggle where sometimes we were not given the rights to be able to see patients and carry out some of the procedures within the NHIF, similar to what we saw the other day. And it really took some fight. And by then I remember Ondieki was in the association, and by then was the secretary and played a big role. And I'm even happier that I have seen Mr. Gilbert Osoro, who really understands the history of where we have come from, because he's one of the people who are really involved in that conversation, the negotiations, until I can see there is somebody who is saying they can't hear me. So I don't know if probably you can't hear me, all of you, or it's themselves who are having an issue.
Mr. Chairman, we can hear you loud and
We,
clear.
we
Maybe
can
they
hear
check
you.
on-
We can hear Peterson. I think they need to look at their microphones.
Okay, John Kisa, just log out and log in. Sometimes that happens with Google Meet. And so it really took a lot of effort and struggle for us to get to where we are today. I remember by then we had demonstrations, we had strikes. The DMS then, I remember that was Dr. Jackson Kioko, did a letter informing NHIF to give us the rights to do what we are supposed to do. And that was not honored. Then we continued with the struggle, where then the PS Corel, did the same. But that was also not honored until we reached the level of the CS, that by then it was Sicily Karaoke. We wrote a letter, and it's by then that we were able to be given this right. So there has been an issue of conflict between the insurer, the public social health insurer, and the clinical officers that has been documented from then. And mostly because there has also been conflict of interest with some of the people who sit in the board. So that was in 2018, 2019. Then the problem came when now we transited then into the Social Health Authority around October of last year, and where our specialists were able to carry out some procedures where we were able to admit and see patients under the NHIF. After the rollout of SHA, then they decided to remove all the clinical officers and all the other health workers, and were left with only those who are registered under the KMPDC. And not only the doctors were allowed to do that, the doctors, the cohort who are under KMPDC, the dental technologists were also allowed to do the same, and I think also the opticians or the optometrists, just because they are registered there. And that is where the genesis of now the current problem with the Social Health Authority started, which of course, as you know, has also taken the same kind of struggle for us to finally get away forward. And I think it culminated with that return to work agreement that then saw an agreement between the Council of Governors, the Union, the Ministry of Health, and the Social Health Authority that provided that all the procedures that were being done before under NHIF, all the rights that were given under the NHIF would be restored. I understand that there is still some challenges, and especially on the admission side. And I think that is what we'll be addressing today. I'm sure Ondieki will be telling us about those in the private sector, about the issues of empanelment and e-contracting, and the challenges they are going through. Mr. Fred will also be telling us about the practitioners and the challenges that they are going through. And I hope that at some point we're also going to open it up to the audience so that they can also contribute, even as they continue to contribute through the chats, so that the people we are having from NHIF, Mr. Gilbert Osoro, who is our friend, and Mr. Douglas, or they can actually be able to answer these questions, and we see how we can collaborate instead of being adversarial. We see how we can collaborate so that we get our rights to see the patients, and also as we do that, of course, we'll be helping the Social Health Authority to meet the objective, which is to ensure that patients everywhere get their right to access health services, and at the same time that they are also protected from the catastrophic financial harm, because that is what the Social Health Authority is actually supposed to ensure. So I have decided to summarize, because today is really about the practitioners being the owners of the facilities and those who are in practice, wherever they are and they are facing challenges, to be able to bring those challenges so that we discuss with the people from the SHA and we get a way forward on how we are going to resolve them. Thanks a lot, Mayek, and back to you.
Thank you so much, Mr. Peterson. You've given us a brief introduction. So I'm told our GS is in the room. Let's give him some minutes to settle. And as he settles, I want to invite Mr. Eric Ondieki. Ondieki, are you there? Kindly give us a brief on the situation of SHA on the ground, attaining the clinical officers. Mr. Ondieki?
Thank you, Mayek, and thank you everybody in this meeting. First and foremost, I want to applaud KUCO for coming up with such an initiative so that we can all get in touch and understand matters on the ground. As you all know, this is a journey that I think, as Washira said, started a long time ago. And I'm very happy that this time again, we had an agreement despite the struggles. And I want to applaud Mr. Gilbert Osoro and Douglas, who have been very supportive to my members in the private sector, being their chairperson in that capacity. So I think from February, sometime mid-February, there was an agreement that saw us get recognized by SHA in terms of our facilities to be contracted, those registered with the Clinical Officers Council. That has to be very clear. That as we are speaking today, any facility that is registered and licensed by the Clinical Officers Council is eligible to e-contract. Now, e-contracting itself is a self-contracting tool. You do not need anyone to come and do it for you. All you just need to do is to log into the system and follow the procedures that are there. We have to note that this system is interlinked with the COC database, so you cannot just do it from anywhere. Whether your facility is registered with KMPDC or COC, once you key in, your details will be populated and you'll be able to proceed. So I must report here that quite a number of our members have been able to e-contract. I know close to about 90 facilities had registered for e-contracting. And out of those 90, I have about 50 who have already successfully signed their contracts and gotten their login credentials. The remaining 40, most of our members have challenges with technology. They're either in their facilities, most of them are level 2. And remember, these are people that we keep saying you need to improve, you need to embrace technology. And therefore, most of our members do not have, they are finding it a challenge to e-contract, but we've been able to guide them through, and they are now doing it successfully. I must appreciate SHA that they gave us a contact person from the ICT department. And also we got the Digital Health Authority come on board to support us. So we've had operations all through, and the 40 remaining facilities, it's by choice that these members have not completed the e-contracting signing. So once these members sign the e-contract, then I think they'll be able to move to the next phase. One thing I want to make clear to all our members here is that one, and I've realized that most people rush to sign a contract before even reading it, and they end up coming back to me seeking for clarifications. But this is the right forum for us to be taken through and to overcome that challenges. Therefore, colleagues, I want to sincerely report that most of those 50 facilities are running smoothly. We've been able to sort most of their problems, and therefore I'm working with the 40 facilities to be able to e-contract.
Okay, thank you, Mr. Ondieki. That's a very commendable feedback, and we will wish to appreciate the SHA team. So allow me to invite our GS, Mr. Gibore, so that he gives us, and maybe he coincide with you if that is the same thing that is happening on the ground. Mr. Gibore? Bwana GS, are you still in with us? Nelson, confirm.
Good evening. Good evening, Chair.
Good
the
evening to you, sir.
moderators, our treasurer, and members present. I think I'm sorry I joined you late because I was in a meeting until almost 3:30. I joined when many things have already been canvassed, but I appreciate that I've been able to join. I joined when Peterson was finalizing, and I believe he has laid a good ground on this matter. I do not want to belabor on that. As we communicated, this is just to look at the status of the issues we have at hand, the clinician, the practitioners, the facility owners, and the social health authority, which is jointly at the hip with the DHA, that is the Digital Health Authority. And as I've said, yes, we started in a manner that really was confusing, because after the transition in last year, October, we as professionals were allowed to proceed and to continue practicing. And all our facility owned by the council were dropped and ordered not to be accredited or empaneled under the SHA until they have a second registration at the KMPDC, which we contested as the union, that was irregular. Since then, once we had the agreement, that has been so far controverted, and we believe that the progress is ongoing. I think the biggest concern and the challenge that we are talking about is the slow transition. It's okay, I'll call. Is the slow transition because we have facility close to close to, I think 900 between 1,200 facilities that ought to be empaneled. You know, I know that they are not able to offer services. The process is still ongoing, but I believe that we will have done the similar way we did with all the government facilities and other private facilities that were already onboarded under the NHF. And actually, we'll have considered all facilities owned by clinical officers registered under the council, and they were already offering services. We will have actually transitioned them in a similar manner. Now, on the other angle of professional, I think after working for some period, there are some people who realized that the clinical officers should not practice independently, and they started tying our practice. And we now managed to have an agreement again. We appreciate that the majority of us are able to give to work and see patient using our own registration number. But I must express my concern that we still have many of the professionals in the oncology department. Those are specialized clinical officers in oncology, the higher diploma, reproductive health, ENT, ophthalmologists. I think I've received around 4 complaints coming from different category. And that's the biggest concern, that they are not able to see their patient. They are told the procedures that they have been doing, or rather functioning for more than 10 years, because like the one who I talked with recently has been practicing as a clinical officer ENT for over 13 years. Now there are procedures that he has been doing and he can't do it because it said that it is reserved for consultants. I think that's an issue we need to deliberately look at and ensure that we can be able to address it. I think what makes things difficult is that we have our government bodies, when we raise concern, even in writing, they ignore and are not willing to engage so that we resolve the issues. We need not to handle these things in a piecemeal, where probably you are saying every time we raise the issue, you say, tell the individual to call us. I don't think that is the way. The intention of the SHA was actually to enable, to act as a catalyst, to facilitate UHC and achievement of UHC, accessibility of services. So at any time you limit the facilities that can see patient under SHA or even professional, and to the what extent, even despite, without considering their qualification, I think then that defeats the same purpose that SHA was established as a framework to attain UHC. And I know sometime you'll call the people in the social health authority, they refer you back to the SHA, the DHA. When you call DHA, they say that, no, this is not our problem, it is the SHA. Sometimes SHA will say that this is not us, it is the people under the presidential team. All those shenanigans, and even actually to some extent even referred to the ministry. All these shenanigans does not serve the purpose to offer services. And that is why, candidly, we have to tackle all these issues and ensure that we have a smooth way of delivering services. We ought need to act as a hindrance to service delivery, as an agent, because then we have no reason to being in place if there will be any clinician limited to offer services to a patient who need those patient services by that time. Now, I also look at it that the issues which is affecting the smooth transition is the hurriedly way that it was done without having considered training our members, the clinical officers, on the system, how to use the system, and how even to contract, among other issues, how to navigate the whole system so that then you don't delay service delivery. The training has, I have been even asking members, like today I came from Marsabit, I had a meeting also from in Meru, Isiolo with my members. There is no training that has happened to them. So I think then that is also a gap that ought to be considered and be addressed as a matter of urgency. I think those are a few issues that I needed to raise, because that is the status that we have, that we still have pending issues that really need to be addressed as a matter of urgency to enable smooth service delivery. Thank you.
Okay, thank you. Thank you so much, our GS. I believe our Deputy Regional Coordinator for SHA is with us and is following through. I want to invite Mr. Okwata to address the challenges that him and the other specialists in our cadre are experiencing, so that I welcome the SHA representative to take us through about the e-contracting sessions and all there. Mr. Okwata, please welcome.
Thank you, Bana SG. Thank you, members. Sorry, I've just come in. I was engaged in another meeting. I wish I would have been given a little more time to just acquaint myself with what is happening before I can discuss. But nevertheless, I think I can still go on. My name is Fred Akwata, not Okwata. It's Akwata, not Okwata. So take note of that, please. I'm the chair of OCOA, Ophthalmic Clinical Officers Association. And If I may just begin, most of the challenges that our members actually have are IT related. And this buttresses the point from the SG that members need to be trained on the system so that they know how to navigate, because this is a big area in terms of gaps in service provision. Because unless we train members on this, then we will continue having complaints here and there, day in, day out. Another challenge, I think that I have learned across the board is that most of the members, again, who are complaining have also not updated their credentials with the regulatory body, that is COC. And so we're asking all members to ensure that their credentials are well updated with the with COC. Quite a number of members again have given positive feedbacks that they are now able to pre-authorize, although the pre-authorizations are taking a little longer, but they are able to pre-authorize. One of the issues that SHA may have to look into, and we may also have to look into jointly, is facility categorization. We have a feeling that facility categorization was actually flawed. That now a specialist in eye care running a standalone clinic, for instance, is categorized as level 2, but still able to provide services being offered at level 3, level 4, and even at level 5. We find that that difficult, because again, if you look at the system, you will realize that level 2 has the most basic, the most basic of the services. And the funny part of it is that you are saying that this person at level 2, who is a specialist in ophthalmic care, for instance, is not able to, carry out certain services at that level because of categorization. So we need to relook at the issues around facility categorization so that people can offer what they are capable of according to their capabilities as well as scope of service. Otherwise, I could come up with others in the course of the discussion. Thank you.
Chairman Okoa, asante sana. I'm sorry for... Sorry, can you hear me?
Yes, I hear you very well.
I'm sorry for misspelling the name.
All right.
Apologies.
That is sorted. Thank you.
Okay, thank you. So we have a few challenges from our specialties, and I want to invite Mr. Douglas Odhiambo from SHA. I want him to address the few challenges that have been pointed out by by Chairman Okoa, and I also want him to update us from their side, the concerns that we've been raising. How far is it? The empanelment of clinical officers, the procedures that clinical officers are entitled to. Because with our scope of training and of practice, we are supposed to do a wide coverage of procedures. So, Mr. Douglas Odhiambo, I want to invite you. Mr. Odhiambo, are you in?
Mr. Odhiambo is not available due to circumstances beyond control. he could not join us this afternoon.
Okay.
My good name is Gilbert Mogambi Osoro. I serve as the head of public education and awareness. For avoidance of doubt, can you confirm you are getting me loud and clear?
Very loud and
Hello?
clear. Please take over.
Thank you. I want to start first of all by thanking the organizers of today's forum. This is one of the things at SHA that we've been yearning for, to have a one-to-one engagement with the clinical officers and work with them in the journey towards implementation of the SHA and universal health coverage. Allow me to share with you progress done since the launch, because this is the first time we are engaging. Since the official launch of SHA, in terms of registration that commenced on 1st of July 2024, significant progress has been recorded in onboarding Kenyans into the Social Health Authority. As we speak this afternoon, a total of 21.3 million Kenyans have been successfully registered into the SHA database. When you look at dependent declaration, and when I talk about dependent, I'm making reference to the spouse. It could be the husband, it could be the wife, and children arising out of that marriage, biological children or children arising out of adoption. We have so far had 6 billion dependents that have been declared by the principal members and are now part of the SHA coverage framework. Allow me to digress a bit there. According to the Kenya National Bureau of Statistics Household Survey Report of 2022, the average size of a Kenyan family is 3. When you look at the 21 million who have registered, and in an ideal scenario, if you multiply that by 3, we should be talking of 63 million dependents, but that is not the case. I want to use this particular forum to appeal to all clinical officers to proceed and declare their dependents. And how to do it is very simple. Log in into the Afya Yangu or sha.go.ke. You go to your profile, you will be able to see a provision where it's written add dependents. What you need to do is to share a JPEG image of either the birth certificate, marriage certificate, national ID, proceed to onboard, proceed to type the full names of the spouse, their national ID, and for avoidance of doubt, you can only onboard a spouse once they are registered to SHA. Sometimes we get calls from members of the public saying, I'm unable to onboard my spouse despite the fact I have the requisite documentation. So remember, under the new law, all Kenyans must be registered to SHA. The other thing I wanted to bring you to speed is non-salaried households. Remember, SHA provides for registration of non-salaried households. These are mama mboga, boda boda, retirees, and people who are self-employed. As of this morning, 4.3 million Kenyans have subjected themselves to what is known as proxy means testing, which is the tool that is used to determine the premiums payable, and it's also used to determine the poor and vulnerable households. Remember, contributions to SHA are pegged at 2.75% of gross salary for those in salaried employment. For the non-salaried households, it is 2.75% after proxy means testing. We have the fourth cadre of people. We have those households that are in need of financial assistance. Those ones will be identified through proxy means testing, and the national government and the county governments are by law obligated to pay for their premiums. When it comes to benefits, or you remember, the benefit package that Kenyans had wanted was validated through a national validation process that happened last year in the month of August. I remember it was around August 18th when we had a meeting at KICC that was spearheaded by the minister in charge, and Kenyans ratified the benefit package. There's one thing I want to make a disclosure. When it comes to the benefit package design process, there was stakeholder involvement through each and every stage. The first stage being identification of services for potential inclusion in the benefit package. It is Kenyans who stated what they feel should be included. The other thing that was done was costing the benefit package that Kenyans wanted. The other thing that was considered was to get data on the population need and the current coverage of the benefit package and interventions that were covered by NHIF. This being a scientific process, the actuaries did compute the total intervention costs and the budget impact. The purpose was to determine the yield, what Kenyans should pay as premiums. The other thing they did was to rationalize or optimize the health benefit package. And finally, in fulfillment of the constitutional requirement that any major decision that impacts on the public, there was to be validation by stakeholders. Now, having said that, sometimes we get questions, people asking us, where did you come? The costs that you administer are too little. And we are constrained to tell them that this is what we can finance sustainably. Allow me to also share an update on share performance since the rollout. Now, facilities have been paid, though albeit the payments have not come fully. Of course, we first of all look at claims and make payments. Allow me to mention something on the primary healthcare global budget performance. In January this year, we changed the provider payment mechanism for the outpatient benefit package for the primary healthcare facilities in level 2 and 3 and the government level 4 facilities. Now, 5,509 facilities are currently participating in offering outpatient primary healthcare facilities. The global budget for January and February was 1.8 billion, with the GOK facility that the private providers did not embrace the global capitation budget at the time of rollout. When you look at the payments that we've done, faith-based facilities, we have 316 hospitals participating, and in the current 2 months, they were paid 147 million. The government has 3,374, and they were paid 1 billion shillings, and the private facilities at 1,819, and they were paid 632 million. Allow me to tell you something, and this is where I want you to take very key notes. I was privileged to have been part of the team that went to Mombasa recently to review implementation of this global budget. In Mombasa County, I noted that for the facilities that participated in the global budget, they have witnessed an increment of 600% reimbursement. I want to give a case of Mombasa County facilities. Previously under NHIF, every quarter we used to reimburse them approximately 6 million. But in the current global budget, we've been able to reimburse Mombasa County 47 million. I want to use this particular forum to demystify the global budget. Under NHIF, we used to pay between 250 to 300 shillings per quarter, which translates to basically between 75 to 100 shillings. But under the global capitation budget, we are paying for number of visits multiplied by the severity of the disease. Allow me to just share an hypothetical scenario. Under global budget, and I'm happy Ongage is here and some of the facilities that are practicing that, you find that the average payment for a case of malaria is about 1,200 per visit. I noted with concern the other day when I went out to the field and noted that some of the facilities have an erroneous perception that we are paying 75 shillings. I want to appeal because these facilities in level 2 and 3 are the facilities that are owned by clinical officers. Use this particular forum to tell the facilities that are participating there is a big opportunity for growth if they enroll to participate. Uptake has been, after we've paid capitation, of course, some facilities have moved with speed to join the bandwagon. The other thing I want to share is that on the issue of emergency chronic critical illness fund, whereby there was a review of the tariff and what is happening currently, the tariff was reviewed from 4,480 to 28,000 per day for ICU rates and HDU. For chronic illness, there was also a review of the same, whereby previously we were paying 400,000 for cancer. That is hematology and the clinical services. But the fund, having listened to Kenyans, has provided a reprieve. For management of cancer, patients who shall exhaust their shift limit shall have an additional 150,000 that they can be able to utilize. The other thing perhaps I want to say is that since the rollout of SHA, Kenyans have been able to access services and we have been paying. And what the government has said through the new CS, every 14th facilities will receive payment. But I note with concern because this morning I noted some level 3 facilities that we were able to note that their bank details had not been updated in the SHA database. I want to appeal that for those of you who run facilities, it is paramount to ensure that your bank details are aligned to what is in the licensure, because we are finding scenarios whereby facilities, the facility name in the licensure from the clinical officer's council differs with what is registered in the bank. And as such, we are saying it's imperative that all the details, both in the bank and the licensure, are aligned. Allow me now to respond to some of the questions that have been raised. They say to whom much is given, much more is expected. I want to concur with the colleagues and want to salute Peterson, Chebi, Gibore, Eric Ondieki, and P. Majek for the patience we've had. As Peterson did indicate and Gibore, I was part of the team that negotiated in 2018 for the issue of accreditation that clinical officers, council licensed facilities be recognized. And we also went ahead during that particular time to allow for pre-authorization rights, especially for the specialized cohort that you mentioned, including ophthalmologists, oncologists, and many others. I also am aware there were challenges that arose after the rollout in October that unfortunately the clinical officers were not recognized in the database. I'm aware that my colleagues, Margaret Macharia, Douglas Owino, and the rest of the team have had a conversation with the Clinical Officers Council and the union, and having been guided by the principal ministry, directions were given that we recognize the facilities, and also for the pre-authorization, we recognize the specialized cohort. I'm privy to the fact that there was a time, and I did call on Jeki, that SHA was looking at the clinical officers who are specialized. But I've just learned this afternoon that some of those specialized clinical officers are unable to requisition for advanced procedures. Allow me this, with utmost humility, this being our first meeting, that I'll go back to our management for purposes of getting information and clarity on this particular issue. But I'm aware, Chebi and the ICT officer did share data of all clinical officers in the country, even for those ones who offer specialized services. That far, I can concur that indeed we receive data. On the issue of e-contracting, I want to concur with Eric Ondieki that we had a session, I think it's a month ago, and I was part of the team that did the training on the e-contracting process. And I'm glad to report that a number of facilities, as Ondieki indicated, around about 50 of them have been successfully onboarded to SHA. Their contracts have been processed and they are currently offering services. As we indicated in that particular meeting, that we will bend backwards to accommodate all facilities, including sending officers to support those facilities that may have limited digital literacy to onboard. What I want to say is the issue of e-contracting is a personal responsibility. It's equivalent to filing tax returns. We have made it so seamless that the onus is on the facility owner. But having said that, we are ready and willing to come to your facility and ensure you are properly contracted. And as Ondieki said, it's imperative you also read the contract, because we have had instances of some of your members who have signed the contract only to realize that some of the procedures they wanted to do were not captured in what they signed up for. And you see, sometimes variation of contract is very difficult, and sorry, we end up having challenges at the end of the day trying to vary the contract. We did develop a brochure or a flyer, which is in soft copy, which I'd like to share at the end of this meeting. It's so simple to use. We will be able to share through either your chair and Gebore, so that you can be able to distribute. But allow me to say this, when it comes to the issue of e-contracting, that when it comes to contracting, there are a number of things you need to have before you embark on that particular process. One of which, you must have your licensure, which is updated, the latest. The other thing you need to do to have before you embark on the process is the clinical officers registration, clinical officers council registration number rather. The other thing is healthcare facilities stroke providers administrators national identity card ID. The other thing is the telephone number that you want to use to register, and if there's one at the facility, you can also provide, and of course attach your license. You also need to have a reliable internet connection and access to a compatible device, and we are talking of a PC, tablet, or even a smartphone. And how to go about it is you open the login page, but before you do so, you must have gotten the credentials from either the clinical council to enable you to log in, because remember, this is a secure platform. And what you need to do is you open your preferred web browser. In this case, we are talking of Chrome and Firefox. And you type in the URL, which is www.sha.go.ke/resources/e-contract. You will proceed and be able to register. But having heard what Ondieki has said, we will plan with you when we can be able to do further training for the 40 facilities. I also want to request our team at Legal to come and take you through the salient features of the contracts that you sign, because I note majority of the people sometimes just sign, and then when issues arise is when they come to our offices. Now, we have a contact person, as Ondieki said, at the SHA headquarters. She's called Vivian Rono, whom was nominated to assist healthcare facilities. We also have Peter Muli at the headquarters, and I'll be able to share their emails for the facilities that have a challenge. I'm aware that DHL also seconded an officer to support facilities to be able to onboard. I know Brother Gebore raised an issue of slow transition. Indeed, a journey of 1,000 kilometers commences with a single step. the transition was a bit slow, but we have gained momentum. As we speak, we are on overdrive year 5, and currently, if you look at the people who are onboarding and the facilities that are participating, it is proof that indeed Kenyans are embracing UHC. But I noted, Gebore, that we have only 90 facilities that participated during the e-contracting. I noted you indicated there are 1,200 facilities. I want you to be our ambassadors for the remainder of the 1,110 facilities. For us to attain UHC, we need to have every facility on board. Currently, you can see the number of facilities participating is very little. So reach out to your colleagues and tell them to onboard. On the issue of appeal to onboard automatically, as Gebora had suggested, I want to take you to the provisions of the act that talk of how do we contract facilities, because the act is very clear. When it comes to contracting, the provisions of, I think it's section 31, explicitly define how a facility can be onboarded. Now, what you need to know when it comes to onboarding, there are very clear procedures on how it can be done. One is that the authority is guided by the provision of the empanelment as cited in the Social Insurance Act, Section 33. And the subsections are as follows: that the authority shall make payment out of the fund to healthcare providers or healthcare facilities that are empaneled and contracted in accordance with the provisions of this Act. Number two, a healthcare provider or a health facility seeking to be empaneled under the Act shall make an application to the body responsible for accreditation for quality care in the manner prescribed by the Cabinet Secretary. The body responsible in your particular case is the Clinical Officers Council. Number three is that upon the publication of the list of empaneled healthcare providers and healthcare facilities on the website, in the Kenya Gazette notice, the authority may contract the health facility or healthcare provider within a period of 30 days of the date of publication of the list. There is a timeline attached to it. When you look at the social health insurance regulations, Section 31 talks of empanelment, and when you look at the subsection, it goes further to state that the authority shall pay claims to empanel and contracted healthcare providers. And it says that in Section 2, despite the provision of Sub-Regulation 1, the authority may pay claims to healthcare provider that provide emergency treatment in accordance with the benefit package. So for the 1,100 facilities that are not contracted, in case of emergency, then they can be able to offer services. And it further says, the authority shall continuously empanel healthcare providers and health facilities. Let me pause there to allow further questions. And for the ones that have not answered, I'll go back to them. Over to you, Chair.
Thank you so much, Mr. Gilbert. That was very comprehensive. And true, I'm a beneficiary of ASHA because I am in a level 3 facility. One thing that I know is that initially there was a miscommunication about
capitation.
About capitations, correct. So most of us, we actually billed 75 shillings. But I'm happy because now SHA has actually expanded the package, and for real, it's working. So I want to open this discussion, but before I open the discussion, let me appreciate you for creating time to be with us, Mr. Osore. Please don't leave the call, because I want to invite yes, I want to invite, allow me to invite just one person. Just a moment. I just want to confirm. I don't want to misspell their names. Mr. Gilbert Osoro, from the head of Public and Education Awareness. Karibu sana, Mr. Gilbert.
Thank you.
Thank you, sir.
For clarity, the person who has been speaking to us is Gilbert.
Yes, Gilbert Osoro.
Oh, sorry. So Gilbert has taken the position of Odhiambo.
Douglas could not make it as I invited.
Okay, fine. Mudama, that is very bad of you. Okay, so I think we let me take it to Mr. Gibore for a quick update on it before we open the panel for discussion, if I'm allowed. Mr. Gibore?
Yeah, you can hear me?
Yes. Loud and
maybe you come up what you wanted me to respond on. I think my network was going down. I didn't hear you well.
No. We have been given a comprehensive update by Mr. Osoro.
Yes. Okay. Yeah.
So I wanted you to tell us if that is the exact thing that is happening on the ground, and if we are contented with the update from Mr. Osoro, and what do we still need to push so that we are fully onboarded and empaneled into SHA. Thank you.
Very well. I think, let me be very specific that Mr. Osoro is a good friend of mine, and he knows to some extent he is serving in an institution where allegiance he must stay to. And of course, I have been telling him that he's a good man. But I must say that we had an agreement after a long push, unnecessary, because then, as he says, that's what the law provides. But someone sat down and they felt like that should not be the practice. We have held a position that probably it is not non-medic who are orchestrating all these problems. These are people who are feeling that clinical officers are taking their position. Indeed, this is about market. It is not about value for service. It's not about quality of services. And therefore, even when I see the clamor for centralized regulatory body, this is all about the issue that people think that it will add value to service delivery, but that's not that's far from truth. So let me say, largely I agree with what Osoro submitted, but I must say that when we had the last agreement, which was sanctioned from the office of the head of public service, was also sanctioned in the office of the deputy president. After the ministry had fully agreed, we agreed that we reinstate all services that clinical officers were offering previously under NHF. That has not happened, Mr. Osoro, and it is deliberate. You know very well there was a team that you put together. Even some of the issues that they did, the services that they tabled, they were still censured and they dropped a number of procedures, or even diagnostic and curative services that were dropped. Procedures that were dropped unnecessarily. To date, still, there are members who are still complaining, which we believe that should not be the subject. And that is why I feel there could be some rogue officer in the Social Health Authority making Social Health Authority to look like a rogue agents. I don't know whether to say to you that is a good word to use, but I feel that there are people who portraying the SHA in a bad way and making it to be more of a contestation between the practitioners and versus probably the authority. We have said, and of course, unfortunately, as I said, you are never available for meetings. We have written letters of concern. The Social Health Authority is never available for any consultation. So until then people go on strike, that's when they tend now through the ministry to call people together so that we have discussion. So that is unnecessary. And I want to say the issues which is affecting practitioners and the private facility owners who are clinical officers in this respect should be addressed, and they can only be addressed conclusively by virtue of being deliberate and having engagement that are likely to address the issues that are still pending. But I don't know how good it is that we continue complaining all the time and the person who is suffering is the patient that you ought to be supporting to get the services. And that is, and I believe that a majority of the people who are here will actually attest to what I'm saying, that we have a problem. To the extent that there are clinical officer who cannot order an ultrasound to facilitate the service delivery for a patient who is probably, I want to give a good example of a patient who have checked in a hospital, is in pain, and I'm doubting that this patient could be having an ectopic pregnancy. I can't do a scan because of the bureaucracies that now are being erased by the agents, by the SHA. And that is what we ought to avoid, Mr. Sorry.
Through the chair, can I respond?
Yes, please. Sorry, I lost my network. Yes, please, Mr. Sorry. Go on.
Thank you, Brother George Gibore. And indeed, as you've indicated, I was part of the team that negotiated the 2018 agreement. I remember we sat past up to 1 a.m. with you and Onyeki and others. And I'm also privy that indeed our team at SHA is ready and willing to work with you. And to that effect, I'm aware there was a team that was set up to address the issues that you have highlighted, including pre-authorization, the services that were offered under the DEF and NHIF, including diagnostic procedures and others. And I want to say it is works in progress, as I did indicate that a journey of 1,000 kilometers begins with a single step. From where I sit, I'm happy we are speaking. Reading the good book, the Bible tells me in Psalms 133 that how good and pleasant it is when God's people live together in unity. And at SHA, we want to work with the clinical officers because you are the people who will enable this country attain 100% universal health coverage. And I want to believe it will be during our time. But having said that, I did promise that I've captured whatever you have raised. I will be able, and I hope this is the beginning of the many meetings we'll have to get some response to your feedback, because he's the one who sent me and Douglas to participate in this meeting. Now, on the issue of meetings, I've just learned today that, as the Gebor indicated, that sometimes our teams may not be available. But from our end, and Douglas and Onyeki will bear testament to that, we were ready and willing to host further trainings for the healthcare providers who had wanted to be onboarded to SHA. And still we are ready. And that's why I said, after today's meeting, we will call another meeting convened both by you and us to take your membership on the contract. Number two, to take your membership on the benefit package, because we have never trained officers on the benefit package. The other day when I was in Mombasa doing monitoring and evaluation for Taifa Care, I got to learn that unfortunately information did not filter to the ground, and the officers I interacted with were asking me, what do you cater for? And I want to believe this year, if you have an AGM, you will invite us to make a presentation to your team, and we have, I'm happy, I've learned that you have meetings every Wednesday, so we can schedule one Wednesday to take you through the benefit package from the primary healthcare. We take you through the global capitation budget, which stands to benefit your members immensely. We take you through what SHIF caters for. We take you through the emergency chronic critical illness fund, including the emergency care that I've mentioned. We'll also have themed meetings. Like now, we can have a forum for emergency care. emergency, chronic, critical care, so that your membership understands in a layman's language what that particular benefit package caters for. So we are ready and willing. When called upon, we'll respond as faithful stewards. Thank you.
Sorry. Thank you, Mr. Osore. I want to, now we move to the second session of the program of question and answers. And I want to invite my counterpart, Mary Boniface, to take us through the session so that I will come back when we are closing the session. Mary Boniface, please.
Thank you, Philomena. Before we go to questions, Fred Akwata, you have something to say? Can you hear me? Thank you so much, Gilbert and our other panelists. That has been a very elaborate discussion. I know this is one of the sessions where our members have a lot of questions, and it will be good for us to measure into the questions. But just before we go into the questions, we know that clinical officers are very key in implementing these healthcare reforms, and in this case, there is SHA, because it comes with a broad promise of universal health coverage, where we're talking about equity in access, we are talking about financial relief to the Kenyans, and of course, access, like no limitation to access in healthcare. And clinical officers play, because we at the intersection of policy implementation and patient care, and therefore we are at the very core of health systems in Kenya. So therefore, these reforms comes with a lot of opportunities for us as clinical officers. And just before we go to the question and answer, I would like us to quickly touch on what opportunities are there for clinical officers in this. And I want to welcome our panelists, Ondieki and Osoro, again to briefly speak to this, and then we move to questions. And let me start with Eric Ondieki, please. Is Eric on? Benson?
Yes, he is in.
Eric, can you hear me? If not, then Osoro, please say something into that.
Sorry, there are immense opportunities that exist for clinical officers. As I did indicate during my opening speech, I deliberately focused on the global budget capitation. The reason being that majority of the facilities in level 2, 3, and 4 are owned by clinical officers. And they might have missed the bus, allow me to use that word, because when we rolled out the global capitation budget, some people went around and then erroneously passed a message that we were paying 75 shillings per capitation visit, which was wrong. The purpose of the 75 shillings was for purposes of budgeting. And the way it works is that we were to get the population of a particular county, multiply by 75 shillings. Thereafter, if you are 2 million in your county, times 75, the first participating facilities will divide the money that has been set aside by the budget. The county was to be treated as a primary care network. And that is why in Mombasa, you found a disease like malaria being reimbursed for at 1,200. And the good thing with this global capitation budget, it does not restrict on the number of visits. So if you come today and you are unwell and you come tomorrow, of course, we will be able to cater for that. That is why I want to use this forum to encourage your officer, the clinical officers who own such kind of facilities to move with speed and ensure that they are onboarded. The other thing I'm seeing, an opportunity once we streamline this issue of standalone HCPs that are offering specialized services. I had my brother Fred Akwata, and Fred has been my longtime friend. I know he still remembers me. I did serve as their manager in Kisumu. We need to look at these standalone facilities. Remember, they're offering specialized services ophthalmic, we have oncology, and many others. There is need, as they correctly indicate, facilities in future with a view of ensuring that they are reimbursed as per the service level they offer. I remember when I served as a manager contracting, during that particular time, we had come with categorization of optical and I think dental units, what was in level 2, in level 3, up to level 5 that were doing surgeries under local anesthesia. So there is need to do that so that we reimburse these specialists based on what they are doing. The other opportunity that I'm seeing is for us to quickly move with speed, and it's a shared functionality to undertake training, because it's not enough to be onboarded, because some of the facilities that are onboarded, again, because of the new system, are not offering, that they are not billing. I don't know why, but when we did a baseline survey, especially in government facility, you'll find that the staff manning those facilities are not competent enough. What I want to tell your membership, SHA is digitally heavy. So apart from your training, which is in clinical medicine, there's need to invest a bit on digitalization. You can do a course in Excel, Word, and many others to up your skills, because this is the route the government is taking. Everything will be done on the online platform. As we continue implementing the primary healthcare, there are immense opportunities that exist. As you note, apart from PHC, which I've mentioned, the other benefits that are available in primary healthcare include in patient screening and optical services. And when you look at the issue of screening, which will, I'll start with the outpatient care services. Now, when you look at the scope of cover, it covers the management of acute and chronic conditions, consultation, lab investigation, imaging, prescription medication, vaccine, outpatient procedures, and management of mental health conditions. Let me underline the word mental health condition and health, wellness, and counseling. In recent past, we have had a spike of mental health conditions, depression, schizophrenia, and many others. And the issue of drug and the substance abuse that has indeed afflicted some counties in Central and Coast. And one of the things we note is that the uptake of mental health benefit package has been a bit slow. For me, where I sit, it's an area that your officers can invest in. The other thing they can look at is the issue of optical healthcare services. Now, the scope of cover of optical healthcare services, which is eye health, includes eye health education, eye test, and treatment for refractive errors through eyeglasses. Our limit is 1,000 per household, but strictly for beneficiaries below the age of 18 years. And this is available in level 2 to level 4 facilities. When it comes to inpatient, we are talking of management of diseases while admitted, consultation, bed charges, nursing charges, lab and radiological examination, drugs and post-discharge medication, physiotherapy, and administration of blood products. And the tariff is 2,240. That is in level 2 and 3. And the limit of liabilities is 180 days or 6 straight months. This is an increased rebate, and Ongeki will attest from what we were offering in the past. But I want to focus on the new areas or opportunities for growth, screening services. And the scope of cover for screening services is that screening will be done as part of the initial assessment to identify potential health concerns under outpatient services. Now, the access rules is screening for common health conditions to be financed under outpatient services, and the targeted screening for the top 4 cancers with the highest incidence rates, that is breast, prostate, colon, cervical, that will be rolled out in year 2 of maturity of the scheme. Long and short, for those of you who own facilities, start preparing. When these screening services come, you can be able to benefit. Thank you.
Thank you, Soro.
Thank you so much.
Let me chip in. Indeed, there's a lot of opportunities, and I've really endeavored to encourage our members to take this opportunity and grow their and expand their facilities. The very positive thing I want to tell our colleagues, let's stop complaining. Let's get to do the real work. And again, I've noted most of our colleagues working in public facilities, they do not interact with this system quite oftenly. And therefore, when they're given an opportunity to use the system, maybe in a private setup, then they are not able to navigate through. This becomes a challenge. I want to dispel a notion. Number one, you will not be able to admit a patient, then your pre-authorization, then you cannot be able to pre-authorize. Once you are able to admit a patient to the ward, especially those on public service medical scheme, we used to call it comprehensive cover under NHIF. If you're able to admit that patient to the ward, then be sure you're able to use your credentials to pre-authorize for services. Like my colleague Fred said, we are interesting characters. You do not update your phone numbers with COC because there's a message that has to come to your phone for you to enter it for the pre-authorization to go through. Then you start complaining that SHA is not listening to you. The only issue I have of sorrow is with my colleagues, and I don't know how we will cure this disease. It was there in NHIF, now it has been transferred to SHA. Response to emails. Even acknowledging an email to say received, it's an uphill task, especially with SHA. The same disease has been transferred to customer care at DHA. That is one area. If you send an email today, be sure you receive a response if the earliest after 2 months. And I want to single out the CEO DHA. The moment I send an email today, he'll either acknowledge as received or we give a response. So my good friend Gilbert, kindly pass this message to management accounts, those people at accounts, managing the management at accounts at geo.something. Please, can they respond? Because Some of us, and I'm a classical example, I transitioned from NHIF to SHA. All my account details have never changed. I received payment last in October last year. Up to date, I'm still wondering whether my accounts disappeared. I have resent those accounts twice to that email. Today I wanted to send a third time. No one has responded whether they received the details. No one has acknowledged whether they received the email. And therefore, my facility is wondering whether payment is being paid selectively, especially capitation. So if we've moved to a point of efficiency, then communication must also be efficient. We cannot choose to do things selectively. Overall, if I give you the performance of SHA system, excellent. It's so efficient. You're able to see your things real time, and I'm very happy we've eliminated about 80% of the middlemen we used to have. I don't need to call Osoro for my contract to be released. So to our friends from SHA, kindly let us have timely responses that will help you. Additionally, I want to encourage all of us here to be champions of SHA. That is the reality on the ground. We are not politicians. When you fall sick, it is you alone. It is your relative. It is your friend. So before you start complaining that SHA is not working, leave it to the politicians. Our work is to encourage our patients to look at SHA positively and be able to register. If you are not able to do this, kindly guide them appropriately. I have done this in my facility and it has worked so well. Even those who are doing means testing, they are now coming back to say, we want to pay our premiums because they have been able to see the benefits they have been able to get. The few teething problems, I'm certain if we sit down, and I'm very confident, once NHIF now competitively and actively appoints substantive directors, managers for various departments, then things should be able to move smoothly. But by and large, the few challenges we have in terms of late payments, some of us not receiving payments completely since January, I think it's an issue that we can follow through. Then secondly, if SHA has committed to pay claims by 15th of every month, I'm wondering, 15th was yesterday. Yesterday. I saw quite a number of my members coming to my inbox wondering, when are they receiving even their first capitation fees for the month of March? So as it is, Gilbert, the last training that I think I attended, the commitment was that we need these reports. Remember, level 2s now have been denied access to a report tab. So they're not able to track their claims. They're not able to track their payments. They can't tell when payment is done. So if SHA has paid, for instance, capitation, which I'm aware money was released last week on Thursday. So did it pay for capitation? Did it pay for inpatient services? Or if it did not pay, when do these hospitals will expect their capitation payment for March so that they are able to plan their activities? Because you have undertaken, the last training they said, by 28, they'll be able to do analysis of how many people have registered in that primary care network, which is a county. Then by 5th of every month, they shall have computed what each facility is to get. So the main challenge is facilities haven't received their capitation fees. Most of those that were contracted are as early as March from COC. So that's a challenge, and I think it needs to be taken actively. The other thing, we have almost 1,900 facilities remaining. Please, can we have these people contract? It is purely self-done. Do it at your desktop or from your phone. Then let's follow the login credentials. That point, I'll be able to come in and assist. Thank you so much. And I look forward to the Q&A.
Thank you so much, Eric. I
Allow me
know
to,
Gilbert has not listed where
yeah, allow
there are
me,
questions.
yeah, before we move to the
Yes, Gilbert.
questions, allow me to respond to the issues, pertinent issues that Eric Onjeki has raised. I sincerely apologize on the issue of delay to respond to emails. In this time and era, I will pass the message to my colleagues, especially at management accounts, who normally handle issues of updates of accounts. But having said that, I'll humbly use this particular forum to request that I be given a list of all facilities that have not received capitation payment. One. Number two, facilities that have not been paid from October to date, because we are under firm instructions to reimburse facilities. Because what I suspect, and I've seen it this afternoon, a facility that came to my office, when we went to cash office, we realized that there was a variance in terms of what is captured in the licensure as the name of the facility and the bank account. And the new system uses AI. Immediately, there is a slight difference. Even by one letter, it is rejected. So, Onjeki and team, please share those details. You have my email, so that tomorrow morning, I'll walk into that management accounts, give them the list, and also remind them they are duty bound to respond to emails. I'll rest it there and hand over to Mary Boniface.
Thank you so much, Osoro. We have a few questions in the chat box. I'll just quickly peruse through them. To the audience, if you have a question, please raise up your hand so that you can be able to be given the mic. From the chat box, one person is asking, when you're told in a private facility that you cannot get services, does it mean that, or in the name of they don't take share? What does that mean? Another person is asking, what happens to diseases that systems highlights in red that are not capitated? Does it mean such diseases are not paid and the patient is supposed to pay cash? The other one was clarity on capitation. I think that was already clarified. A few days ago, SHA disabled the claim summary tab for level 2 facilities. Please let us know what informed this and the options available for tracking disabling the claim summary. Those are the questions that we have on the chat box, and I think these ones go to you, Mr. Osoro. Also asked, how does it pay level 2 providers given that it's primary healthcare fund? Probably you can take those ones first.
Thank you, Mary Boniface. Allow me to start with the question of no service by a private healthcare provider. I would have requested the person who sent the question to first of all confirm whether the facility is empaneled and contracted by SHA, because facilities that are empaneled and contracted by SHA by law have an obligation to offer services as per the scope of cover they signed up to. So that is actually a violation of the contract they've signed up to, because the contract terms are very clear that they offer services to our members. But if it's a facility that is not accredited and empaneled, then it can be deemed to be within their rights. So we need to be very clear exactly what, whether it's empaneled or contracted. The other issue is system, where the system highlights some diseases as red. Now, this is the first time I'm hearing it, but what I can say, The red is an indicator that that facility is not licensed to offer that scope of cover. There could be procedures for higher level. So allow me to investigate. I'll also be able to offer a detailed report on the same, because this is the first time I'm hearing of some diseases being highlighted in red. Now, claims summary tab in level 2 that have been discontinued is also a new development, but what I'm aware, there was a system upgrade that is currently ongoing. And I'm to believe the reason that that tab has been discontinued is to upgrade it, because we are aware level 2 facilities have been asking for a reports module where they can generate reports on claims that have been paid, claims that are pending, claims that have been rejected. So I will also be able to get a report from DHA and ICT on what is happening in that claims summary tab. Now, when it comes to payment for claims in level 2, remember, we have the benefit package and tariffs that was passed by Parliament. That is Legal Gazette Notice number 147. It defines the amount that is paid for level 2 facilities. I've just indicated for level 2 inpatient, it is 2,260. That is the provider payment mechanism. It's actually 2,240 for inpatient treatment. That includes management of diseases while admitted, consultation, bed charges, nursing charges, lab and radiological exams, drugs, and post-discharge medication. When it comes to the issue of optical health services, the tariff is Kenya shillings 1,000 per household and below the age of 18 years. When it comes to screening, which will commence in year 2, each procedure to be screened will have a separate tariff for breast, prostate, colon, cervical cancer. And finally, I did indicate that for the global budget, capitation will pay 900 per person per year, but that is for purposes of estimating the budget that will be paid to the county. Allow me to rest it there. I think I've answered your 4 questions.
Just to add on to
Thank
what
you.
Gilbert has said, sorry, Mary, on the issue of missing features from the dashboard, I want to inform the group that I managed to have a conversation with Savannah Informatics on what happened. And they informed me that that was a directive from the DHA that they felt level 2 does not need that feature. They were just developing something else for level 2 for them to be able to track down their reports. But I did an email yesterday to the CEO, Digital Health Authority, Anthony, and of course, he acknowledged that he had received the email, so I'm just waiting for feedback from him. And this is a conversation that I have had with him last month. That's how we ended up getting the dashboard come on board for level 2s. So that's an issue that I think I can follow with you, Osoro, because I'm well versed with it. The issue of private facilities denying anybody services, I think, Gilbert, I have noted this behavior even from public hospitals. Patients are being asked to pay a certain amount of money before they are given these services. I'm not mentioning the facility in particulars, but I have noted this trend very rampant, and this is especially to outpatient services. There's somebody who asked on capitation how it is being paid. I want to tell you that, as Gilbert said, maybe you are late. This time they have said it is being reimbursed, number 1, how many patients visited your facility. Number 2, what is the average disease weighted that you saw? For example, if you had 5 patients for diabetes, 2 patients for hypertension, 2 patients for pneumonia, and 50 patients for URTI, do not expect to be paid the same amount of average cost for diabetes, as is the case with URTI. So every disease is weighted, and I think I shared that computations to all of us in our private practitioners group, but I'll endeavor to reshare it again for you to be able to appreciate. That is the much I can add on to those questions, unless there's something else, Osoro, that you need me to clarify, because I think I've really interacted with this system quite a lot.
Yeah, just to expound on what my brother Ongeki has said, I've shared something on the wall, but to add on what Ongeki has said, the new capitation model, the amounts and allocation will be determined as follows. The following factors will determine the amount allocated to each healthcare provider. Number one, the total number of cases treated. Number two is the weight of the conditions, malaria and others. They each have been given a weight and the amount allocated to each county. As a result, there may be cases where two hospitals with an identical number of cases seen receive different amount, and that allocation and disbursements will be done monthly. I'll post that to the wall for avoidance of doubt. Over to you.
Thank you so much, Gilbert and then Sondieki, for that. We have two hands, Samuel Waidanchi and then Stephen Mudama. Samuel, IT, you can give the mic to Samuel.
Ready.
Samuel, can you hear us? Mudama, please.
Thank you, Mary. Mine is very brief and a request to Gilbert and the SHA leadership that is here. We note that most of us that are in private practice, and first of all, thank you for the swift response that I've received, and most of my colleagues, especially after signing the contract and getting the credentials and the support that we are receiving. My ask or my request is direct to Gilbert and any other person here from SHA. We note that sometimes when there is stakeholder involvement or engagement from SHA, other than the usual KUCO and KCOA, we have other interests that we need to really advocate and aggressively so as private practitioners. And our request is you incorporate the private practitioners society in these engagements and meetings. And I want to believe that perhaps Ondieki, Kinyanjui, Kinywa, and the rest of the executive perhaps have reached to you, but I want to vehemently request that at this moment, so that we can always advocate and present our interests specifically in regards to private practice, because sometimes we feel that the message is not home appropriately and dry as it's supposed to be. That is my request to Gilbert and any other team from SHA that is in this call. Thank you.
Thank you, Mudama. Samuel, can you hear us now? We still cannot. Fred?
Hello, once more. I thank you, Bwana Osoro, my friend, and the others of the forum. I think Osoro has discussed quite a number of critical issues very comprehensively. Mine is very simple. I just want to, as you go back to SHA when you are seated with your senior colleagues, just give them this message that, number one, make SHA services accessible and simple. Number two, remove the bureaucracies that are being planted by individuals who are already known. And I call this economic wars. No, it doesn't make quite a bit of sense, any sense at all, when you tell me that because I'm at level 2 and Mr. Soro was walking around in Kisumu town and accidentally an insect wing got into his eye, and you're saying that this one must go to level 4 because that's where the service can be, delivered. Yet Fred has been doing the same things over the years, and when Osoro goes to level 4, it is Fred who is going to be, summoned to do the same. Lastly, Ondieki, I think, alluded to this quite comprehensively also. We need support, especially from your IT team. They take too long to respond or don't respond at all. So can you kindly just talk to your IT teams across the country to be supportive of this cause? Otherwise, I think just the way Ondieki has observed, we complain too much and do very little about our complaints. It is time we stop complaining and do what we are required to do, and the rest we leave to those who are mandated to do whatever they are supposed to do. Thank you.
Thank you, Fred. George Misiko.
Okay, good afternoon, everyone.
Good afternoon to you.
So I have a concern that we need to be clarified. Since our claims is based on the number of patients that have visited the facility. So when submitting the capitation returns, do we submit the number of people that are under PHC claims, or we use outpatient registers as the source document?
Gilbert, you've gotten the question.
I got it very clear how they submit outpatient PHC claims. Remember, SHA has undergone digital transformation, and the statutes are very clear that all transactions pertaining to SHA are done on the online platform. So as you attend to patients, they must be captured on the online platform as outpatient claims. And of course, you have to capture the disease code, which will determine what will be reimbursed, because we are looking at the severity of the disease, which determines the amount that will be compensated. When we look at the weighted formula, I think Ondieki can add something there because I know he has submitted some. Eric.
Yes, Gilbert, please come again.
George Misio wants to know submission of outpatient claims and the payment.
Thank you, George. I think for outpatient claims, as I have already alluded to that fact, if you have interacted with the system, once the patient comes in, you have to log in the patient, then you select outpatient, then you select a disease that you're dealing with. Unlike inpatient, outpatient has only an option for one condition. Remember, when a patient comes, you have a suspicion of either, for example, malaria with pneumonia, but you rule out malaria, then the focus is that I'm treating pneumonia. Then once you choose that condition, you click save. Then let's say you want now to, you have to bill. Remember, you have to bill that condition. Let me give an hypothetical example. For example, my patient cost for my drugs is 400 shillings. Then you have to say bill 400 shillings, then you submit. Remember, you are to choose interventions. If you don't choose consultation, lab, all the interventions you want to do, then that will be the end of that process. So if you're charging consultation, hypothetically, let me say 500 shillings, you say consultation, you bill 500, then you save. If you did a lab service, for example, BS, you are able to say laboratory service, which is malaria, I charge maybe 200, then full mammogram was this amount. Then there is down there, when you look at each and every intervention, there is notes. So you should be able to make notes. For example, these are the medications I issued. These are the lab tests that I did. Then you click save. Then go down and submit the claim. Once you submit, the claim goes. Then what happens from the SHA end is that they look at your claim submission at the end of the month. They'll be able to say, Hospital A, you saw 50 patients with URTI, 5 patients with diabetes, 2 patients with hypertension, 10 patients with malaria. Then, for example, if malaria is weighted at 1.0, then we multiply 1.0 times 5. If URTI is scored as 0.5, then it's weighted. Then we sum that total, multiply by the number of people you saw, then we will go back and divide. For example, your hospital saw 100 patients, the county has 1 million people, then all these people are divided amongst these facilities that came. That is how capitation claims are submitted, and that's how the reimbursement model is worked out. I hope I'm clear, and again, I repeat, I'll be able to share a write-up from Rufa on how these computations are done. So please, do not bill outpatient 1,500, then you expect 1,500. Remember, we are using average weighted disease cost for that service. So that is how it works. And if you want to know how much you've been paid per patient, go to your outpatient primary outpatient PHC claims, filter for that particular month, look at the amount of money you have been given in your account, then you'll be able to see how much money you are paid per patient. And ordinarily, it comes to around 200 or 300 shillings, depending on the facility that you have. Thank you, Gilbert.
Thank you.
Over to you, Mary.
Thank you. Thank you, Ondieki. And thank you, Gilbert. I believe, George, you're well answered. We have one more hand from Edelpart Medical Center. Please raise your question.
Thank you, Mary, and thank you, Ondieki, I think, for explaining that, and also Soro for your explanations. Now, I wanted to pick up from where Ondieki just left. The fact that we are able to bill for the disease treated, but also for the lab tests done. What you've said is that, regardless of the amount you've been billed, the payment will depend on a predetermined amount from SHA. I'm trying to look at the implication of this to a private practitioner as compared to a government facility. Because our pricing is not primarily based on the weightage of disease, but sometimes there are many other factors that influence pricing in a private facility. For example, the location of the facility and the amount of rent that you pay, which government facilities do not pay. The fact that in government facilities, the employees are paid by government, and for private practitioners, we have to pay our employees. So I'm looking at the amount allocated, and if we say that they shouldn't be copay, then it becomes, it affects the business model for private facilities. So my question is, maybe this has been answered before I joined, but are we allowed to charge the difference rather? Because if my bill is 2,000 shillings and the reimbursement is 300, then I'm making loss because I have to, for example, my supplies, I procure them myself. as opposed to government where they get supplies from KEMSA, for example. Back to you. Thanks.
Eric and Osoro again, kindly.
Now, let me respond to you, my colleague. Yeah? I think for those of us who have been operating under NHIF, there was what was called capitation, and it was pooling of resources. And a certain number of people had to select your facility, and you had to offer them treatment until the end of the 3 months, regardless of the cost. Okay? That was found to be a skewed way of operating, and some facilities were unfairly getting compensated for work not done. Remember, when a government comes up with a capitation model of 75 shillings, it doesn't tell you that treat this person specifically for 75 shillings. We all know, even in government facilities, 75 shillings cannot cater for anything. What they've done, and what you need to appreciate, the capitation model is primary care network based. Primary care network in this scenario is a county. For instance, let me pick Nairobi. Say Nairobi has registered 1,000 people and Kisumu has registered 100 people. We do not expect reimbursements in these two counties to be the same. Remember, Nairobi will be reimbursed 1,000 times 75 shillings per person per month. Then Kisumu will be given 7,500, while Nairobi has 75,000. What does it mean? Those facilities within Nairobi, studies have shown there are facilities which are seeing a high volume of patients, and therefore they need adequate compensation. And there are facilities which can see 2 patients as outpatient capitation for this month. Can you co-charge? Yes. If you want to co-charge, you will go ahead and charge co-pay, then you'll be able to explain to your client. Remember, the absurdity of this system is whereby this client will go and report and say, I went to hospital A, I was told to pay when it's supposed to be free. You'll be reminded, what did you sign? Remember, this contract, we signed it voluntarily after reading all the contents in that contract. So what has happened, as I've explained to you, in Nairobi, let's assume 10 facilities saw patients and 15 more did not see patients. Justice demands that you compensate the 10 which saw patients, and the 15 facilities also get their fair share of justice by not receiving any coin. Therefore, what does it say? It's incumbent upon all of us to encourage residents within our counties to register in mass for us to benefit with a higher reimbursement fee. That is why you will see Osoro has said in Mombasa, they reimburse at a certain amount of money. When you go to Wajir and Mandera, you find their capitation distribution is so low. Number 2, the number of facilities in that area also determine what you'll get. This is what is there on the table. We are only taking feedback, and I appreciate this feedback. I'm sure you'll be able to sit down with the SHA team once they have been able to constitute their departments fully and have this issue relooked. But one thing I can assure you, capitation fee has consistently been brought down. Initially, it was 100 shillings. It came to 83 shillings. Now it's at 75 shillings per person. I've been with NHI from 100 to now 73 shillings. What it means, kindly go and make sure you enroll more people into SHA under your primary care network, for your primary care network to receive a higher allocation for you to benefit. I'm sure if you compare notes with your colleague in a different county with the same number of people that you saw, they'll tell you they received more or less than what you received. This is what is happening, and this is a reality, gentlemen and ladies. Let us just go out and ensure we register and register and register. I'll be able to organize for training for that particular model to be explained to you in details so that we can all appreciate it. Anything I've missed, I'll ask Osoro to add.
On JP, you've nailed it. That is why when you look at the statistics, 55% of Mombasa County is onboarded to SHA. We are talking of out of the 1.2 million people in Mombasa, around about 670,000 are already onboarded. That is why they received the highest global budget capitation. And correctly, as you've indicated, your county Kisumu is not doing very well. And that is why when it comes to global capitation budget, it is little. But allow me to expound on this. Why this provider payment mechanism? Number one, portability. And Elder Pat, I'll tell you, if you co-charge a patient, next time they'll go to another facility where they are not co-charged. You might end up missing business. But the more you register, the safer for you. So portability and flexibility access. Unlike the previous NHIF model, capitation model, where we tethered or tied people to respective facilities for 3 months, this one, the patient has flexibility in choosing healthcare services within the county, which will improve access to healthcare services. Number two, it incentivizes quality of care. You cannot talk of UHC without talking of quality of care or value-based healthcare. Since payments are linked to the volume, which is largely influenced by the type of care provided by healthcare facilities, facilities have a strong incentive to deliver quality services that meet the needs of the community to attract more population. The better the services, the more people come to your facility. The other thing is disease burden adaptation. This model takes into account the varying needs of the population based on the disease burden, ensuring that resources are allocated to facilities that need them most, especially the facilities that see patients with chronic and other types of illness. There's improved equity. The model can reduce inequalities in access by ensuring that resources are distributed based on the actual health needs of the population. Long and short, we are talking of averting cream skimming that was very common in capitation, whereby when facilities realized a member has chronic ailments, they end on costs. And finally, allocative efficiency. The model allocated resources is based on actuarial service demands. This flexibility enables facilities to respond effectively to varying patient needs and service utilization patterns. We are ready and willing. We can partner with Ondiek because this is an issue that is very dear to your team. We organize a presentation on global capitation. We break it down with real case scenarios on the payments that we've just made to enable your members make an informed decision. But long and short, enroll more members if you want to get more money. Thank you.
Thank you so
And
much.
also remember, under this model, patients are eligible to be treated anywhere within the Republic. I know there's a conversation to ensure that there's ring fencing, that if you are registered in Nairobi, then you can be treated in any facility within Nairobi. When you move out of Nairobi, then I know there was a conversation to try and make provision, a budget for that kind of nature. So if you look at it, it's a more enhanced feature that people used to complain, why am I locked to a particular facility only? So if you move, for example, from Kariobangi and you fall sick when you're in, what is it called? Kenyatta, you are able to get treatment at that point, or in Rongai, you are able to get treatment without being restricted. If you go to a village, that is the whole essence of primary healthcare under universal. So those are the dynamics that are changing, and we'll continue working together to make sure that we all understand it and we appreciate it. When you're starting, I know the numbers are shocking you, but I'm sure once you interact with this system, you get to develop and be more creative, then your numbers will go up. Thank you.
Thank you so much, Ondieki and Gilbert, for that. It is about 20 minutes past the hour, and a lot has been discussed. I know also people are getting tired because the number has been decreasing. So because this is a discussion that you know, it's progressive, new questions as the system advances will keep coming up, and we can always come back and have these meetings so that we
Yeah.
can continue.
Mary, before you finalize,
Yes.
now that Osoro is here in Akwata, there is a concern that is coming from especially the ophthalmology and cataract group that those with facilities at level 3, they're not being allowed to do their cataract surgeries at level 3, which we know that they have been doing under. So that is the first concern. The second concern is about admission rights from clinic officers across the board, which should be actually be granted for all clinic officers because we are the people who actually admit these patients. So I would like maybe Akwata to confirm the first one, and then Osoro can tell us whether this is something that is ongoing, whether there is something being done about it, and then what needs to be done. Back to you, Mary.
Thank you, Chair. Akwata, did you hear that? Fred?
Oh, sorry, my hand remained up after I spoke. I don't have any more issues. Thank you.
No, the chairman wanted to confirm if it's true that ophthalmology clinic officers are not allowed to operate at level 3 currently.
Come again?
We wanted you to confirm if it's true that clinical officer ophthalmologists have no right to operate in level 3s.
Yes.
Yeah, not actually lacking rights in level 3. It is that cataract surgery is not is designated as a procedure that starts from level 4. Well, actually, they can do it at level 3.
Yes, that is the position.
All right,
Osama,
please come in.
Now, let me start with the issue Chair raised on ophthalmologists in level 3 not being allowed to do cataract surgery. Allow me to investigate because I'm aware there was a select team that was put together to engage the clinical officers that was led by Margaret Masharia. I may not be privy to the discussions, but as I indicated earlier on, I'll reach out. I've picked out the issues that you've raised, and I'll be able to communicate to Peterson and Yebore and Ondieki. The other issue is on admission rights, that clinical officers are unable to, have not been granted admission rights. It's also new. Allow me to reach out and confirm or see progress being made. But what I'm aware of, Peterson, is that this was an issue that was being addressed by that committee, and to say it is works in progress. On how far they've discussed, I may not have the details this evening. Thank you.
Thank you so much, Osoro. I think we will keep in touch for further discussion on that. And so that we can be able to conclude, I want to welcome the panelists to quickly have 3 seconds closing remarks. And I don't know whether Katibu is still in. He was traveling, but we can start with Akwata. Fred?
I think I've made most of the remarks that I would have loved to. My final clarion call is that let us all work with SHA and make services accessible and simple for the benefit of our populations. Thank you.
Thank you, Fred. Ondieki. Eric.
Thank you, everybody. And I really want to appreciate this partnership. One thing I want to tell our members, do not be quick to complain. First check on your details, why they are not going through. Last with COC, and for us to be able to be on the same page. Otherwise, I really want to call upon all of us to go out and be good ambassadors of SHA. We are not politicians. Let's focus our key energies on provision of healthcare and encouraging members to enroll onto this. Lastly, all those who have facilities, kindly ensure you have your MFL codes for your facilities. Do not call Eric Ondieki that your claims are not going through, yet you are the problem. If you know your facility has not procured or has not been given an MFL code, kindly liaise with your respective sub-county health record information officers and have MFL codes. The system has been upgraded. Without MFL code, you can't get even payment. Your claims can't even go through. We'll continue engaging, especially for those of us in the private sector. And I'll be able to liaise with Osoro and Douglas for us to arrange for more trainings for you to understand. Otherwise, thank you so much. And let's always endeavor to engage rather than wait for problems to arise. Asanteni sana.
Thank you. Thank you so much, Eric. There's a message for you in the chat box. Please check it out. Gilbert.
Thank you, Mary. On behalf of the Social Health Authority, SHA, I wish to express my sincere appreciation to the Clinical Officers Council for the kind invitation to this important forum. It was a great honor to share insights on the progress that we've made in the implementation of the SHIC Act. I want to commend the Council for creating a platform that fosters open dialogue, collaboration, and shared understanding on the path towards achieving universal health coverage. I want to trust that this is the beginning of the many more meaningful engagements between SHA and the clinical officers as we work together to actualize the objectives of the Act. I also wish to assure you that I'll follow up on the pending issues that you've raised this afternoon and provide feedback in the next meeting. It's been a pleasure being part of today's meeting, and have a restful evening. God bless.
Thank you so much, Gilbert. And there we are, ladies and gentlemen, we come to the close of our today's KUCOEngage 4th edition. And I want to sincerely thank you for taking time to come and be with us. To our power panelists, we really appreciate that. Was quite eye-opening and informative, and especially for our colleagues in the private sector. A lot is still remaining in terms of how we expect the system to be for us to be able to give our services. And like Osoro has promised, this is just the beginning. We have a partner who is willing to walk the journey with us and to help us overcome the challenges so that we can continue offering services to our fellow citizens. From myself and my co-moderator, and we want to thank you all. See you again soon in the 5th edition of KUCOEngage. Thank you and blessed evening. And because we started with a word of prayer, someone please do pray for us. And I don't know, Mudama started. Probably we ask who. George Misiko, because your hand is still up, please cross for us with a word of prayer. George cannot hear us. Let me pray. Heavenly Father, we come before you this evening. We want to thank you for giving us the opportunity to have that very good discussion that we have had. Dear Lord, we pray that going forward, that our issues are going to get solutions, because we are working as a team to ensure that we'll be able to give services to Kenyans without any interruptions. We pray that, Father, you continue blessing the team here, the team at SHA, and our officers on the ground as they practice clinical medicine. Be with us and guide us until we meet again in this forum. We ask for your blessings today and the rest of the days. In Jesus' name we pray and believe. Amen. Asanteni sana and blessed evening.